Except you, of course, Roger.
Okay, so let us start then. So welcome to the Trinidad and Tobago Healthcare UK Forum webinar. We call ourselves TUF, TTHUF. And I'll just do a brief introduction about who I am and who we are, and then I'll go on to yourselves panelists, Dr. Thomas and Dr. Ramroop. So I am the chair of the TUF, which we are a registered charity in England. And we are made up of primarily healthcare professionals and other professionals who are affiliated. Most of us may have born in Trinidad or have parents from Trinidad and Tobago. Our purpose really is to try and contribute to improving healthcare quality and standards in Trinidad and Tobago. We've existed for about 3 years, and we became a registered charity in England last year. So our philosophy is really trying to engage with clinicians and other decision makers in Trinidad to try and contribute, as I said, to how healthcare standards can be improved. And during this presentation, you will hear more about us. And on the chat function, my colleague, Caroline, has put up our website. For those who haven't seen it, we will, you can visit our website there and find out a lot more about our charity, what we do, etc., etc. Before I go to the panelists for introductions, I just want to give a bit of ground rules. So the idea is really to hear from the clinicians, Dr. Thomas and Dr. Ramroop, about their areas of expertise in Trinidad, and we're very grateful for your time. We as a charity, we are independent, and we are not politically affiliated in any way. We're just trying to see how healthcare standards can be improved and what role we can play, if any, with the authorities there. Okay, so, and I am recording this meeting just for people who may not be here, and for future reference, we can play back and use it as a learning opportunity for ourselves as well. This is our first webinar, but we're hoping it won't be the last. Hopefully, as time goes on, we'll have different clinicians come on and talk to us, etc. We do have people joining us from Trinidad, the USA, and the UK primarily. So we hope that it will be an informative session. Okay, so what I'd like to do now, I'd like to just say, so we have two practicing doctors who will be on our panel tonight. We have Dr. Stephen Ramroop, and who is a consultant surgeon, and we have Dr. Clifford Thomas, who is a cardiologist. So let me start with you, Dr. Thomas. Can you tell us then just a bit about yourself, your clinical background, and what you're doing currently?
Right. Well, I'm a cardiologist. I graduated from the University of the West Indies, the Jamaica campus. And after that, I did my internship at Port of Spain General Hospital. And I then specialized in internal medicine. I went to London, UK. I did my membership of the Royal College of Physicians in internal medicine, then went on to do cardiology at the Royal Free Hospital, London. After that, I went to Atlanta, Georgia, and I did a subspecialty in interventional cardiology. I then returned back to Trinidad, and I worked at the Eric Williams Medical Sciences Complex and was a lecturer and senior lecturer at the University of the West Indies. I have done clinical research on various aspects of angioplasty as well as of general cardiology. I am involved in cardiology from all aspects, people who have got sick hearts, and we try to do everything we can. But I also have an interest in preventing people from getting heart disease. A lot of the work we do is a result of very bad lifestyles, which cause chronic non-communicable diseases which lead to heart disease. So as a result of that, I'm interested not only on fixing hearts which are damaged, but in preventing people from developing heart disease. And I would like to lobby with institutions that work to develop healthy lifestyles in the Caribbean, as well as in the world, to prevent people from having heart disease. So that's a bit about my background.
Fabulous. And just tell us, Dr. Thomas, what are you actually doing now in your clinical practice? Or are you practicing clinically at the moment?
Yes, I found my own company, Premier Heart Care.
Okay.
I work with the University of the West Indies or as a consultant at the public hospital. My company, Premier Heart Care, is based in Woodbrook, Port of Spain. I see private patients, but I also provide services on contract regional health authorities. For instance, the Tobago Regional Health Authority, I do a clinic for them once a week.
Oh, I see.
So I'm very busy in clinical practice. My office has recently moved to Evotal Street, Woodbrook. So I'm active clinically, but as I said, I am passionate about developing cardiology services in the so-called developing communities.
Okay.
That's what I really like to see happen.
Thank you very much, Dr. Thomas. And let's move to you, Dr. Ramroop. Tell us a bit about yourself, what your background, and what are you doing clinically now?
Well, I'll follow Keith. I'll follow Clifford's presentation.
Mm-hmm.
I went to Presentation College, San Fernando. I'm a graduate of that beautiful school in San Fernando. And then after I went to Mona in 1980, I spent my 5 years there. Came back in the last year, did my medical student years in the Port of Spain Hospital. Then went to San Fernando, did my internship, and then went across to Edinburgh. I did my fellowship in surgery in 1990, and I graduated from I got my fellowship in Royal College of Edinburgh. Then I did some orthopedics in Glasgow, got my fellowship in Glasgow. About 6 months after, came back. I was appointed registrar, and then I was appointed head of the emergency department in San Fernando. At that time, we were moving the emergency department from the old San Fernando hospital to the new hospital. And therefore, I was commissioned with the task of transforming the emergency room and to include a trauma theater, because doing orthopedic and trauma, they felt that we needed to create a level 1 trauma center. So we actually did that, and with the help of Ian Sami, who was at the time a colleague in UE, we introduced emergency medicine, right, at the San Fernando Hospital training. And we also introduced what is called the Trinidad and Tobago Acuity Scale for triage, based on the CTAS program that they had in Canada.
Mm-hmm.
I was very much involved as the medical director in launching the EHS system, which initially started from the Canadian government in Nova Scotia. And we started with the ambulance system when I was the head of casualty at San Fernando. During that time, I realized that I had a lot of problems convincing the executive management of the board and the hospital, because a lot of the programs that we wanted to introduce in terms of accreditation standards and measurement of practice, it was not being done. So I went and I did my MBA in healthcare management. During the time, that kind of gave me a good idea of dealing with people in healthcare and healthcare strategy and healthcare planning and blah, 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 blah. And after that, well, I was appointed as the medical chief of staff for the San Fernando Hospital for about just under 3 years. After that was finished, I was offered a post as the CEO of the National Disaster Authority, the Office of Disaster Preparedness and Management, which I took up in 2011. And from 2011 to 2017, I served as the CEO, the Chief Executive Officer of the National Disaster Office in charge of emergencies in the entire country. And I was also director at the CDMA level, because being the CEO of the National Disaster Authority, you're also one of the directors of the Caribbean Disaster Emergency Management Agency, which develops regional and national policies in terms of disasters or emergencies.
Mm-hmm.
When I came back, April 2017, unfortunately, my contract ended with the Ministry of National Security. So I went into full private practice. I've been performing in the private practice since I came back from Edinburgh in 1990. So that gives me almost 30 years in the private practice situation. But whilst I was in the, as the medical director, I was also doing some work in the hospital. And whilst I was an ODPM, I was also doing clinical work in my private practice mostly, because I couldn't do public service at that time in the hospitals. When I left, when I realized I couldn't get a job in the last couple of years, I am currently in the final year of my master's in forensic and legal medicine at the University of Florida. It's a sort of hybrid course between online as well as physical classes, but because of the COVID, I can't go up to Jackson, to University of Florida to do any of the autopsy classes within the CSI Academy there. So we're doing it online right now. So I'm graduating in fall with my master's in forensic medicine to keep me busy, but I am practicing. I do minor surgery and orthopedics at I have a little clinic on the top of my property. I do I have a minor operating theater.
Okay. Sorry, you on, can you unmute Dr. Ramroop? I don't know what happened there.
Unmuted, but I'm not
Yeah,
sure
that's it. Yeah, carry on.
You hear me now?
Yes,
Good.
yes.
Yeah, so I have a minor operating theater, so I do a lot of minor surgery. I have a very big practice, quite a number of patients, at least 10 a day comes to my office. And then I do my larger surgical procedures at one of 4 medical centers in Chaguanas, in San Fernando, and in Barapur. So basically I'm busy clinically, as well as I do a lot of administrative work. I am a Rotarian for the past 32 years. So I do a lot of work throughout the Caribbean and in the eastern part of the United States in terms of education, in terms of leadership empowerment, as well as running some charities and charitable organizations in Haiti as well as in India. Every November I go to India to assist in the polio immunization. And this year we're not going to happen. We're not sure what's going to happen this year in November, but it might be the only November for about 5 years I'm not going to India to help with immunization.
Oh,
so
I
that's
see.
it. Yeah.
Okay, thank you very much, Dr. Ramroop. So we have some, comprehensive background, some very experienced doctors with us. So can we come back to you, Dr. Thomas? In terms of heart disease, now, I was reading, and most of us who in the healthcare profession and pay interest to Trinidad and Tobago, epidemiology and so on. Heart disease is one of the highest ranking cause of death in Trinidad and Tobago. And in fact, high incidence of diabetes and hypertension are contributing factors, for example. What is the national strategy for addressing this issue?
Well, as far as the national strategy is concerned, divided into the overall policies and what is in place in terms of primary care, as well as in secondary and tertiary care. Mm-hmm. There hasn't been a comprehensive attempt to put all of these together. And what we have therefore is separate plans for the various types of services. Let's go on the extreme right, where we are dealing with tertiary care services. We have one hospital which is designated as a cardiac hospital, which is the Eric Williams Medical Sciences Complex. Okay. There are approximately 6 to 8 cardiologists at the Mount Hope Hospital. Some of them are employed by the University of the West Indies, about 2 of them, and the rest of them are employed by the Regional Health Authority. So they would be tasked with running the cardiology units where the patients who have severe problems requiring clinical evaluation or in-hospital management would be attended to. At the present time, the tertiary institution functions more or less like a secondary care institution. I should add that that hospital is also a teaching hospital, the Eric Williams Medical Sciences Complex. So instead, that functions more or less like a secondary care level, with the other regionals, hospitals doing the same thing, but with less cardiologists on board. So the Southwest Regional Health Authority probably manages the largest volume of patients out of all the regional health authorities, but with less resources in terms of the number of cardiologists that the North Central. The Port of Spain Hospital, which is in the Northwest Regional Health Authority, also has a very large patient base and functions with one cardiologist. The Southwest functions with 2 or 3, and the Tobago Regional Health Authority doesn't have a full-time cardiologist, but I travel there approximately twice a month to provide specific services for them.
So sorry, Dr. Thomas, can I just interject? And I just want to say something to all of our participants. Please use the chat function to type in any questions you would ask, and periodically I will pick them up and put them to our panelists. And we will have some time for direct questioning as well later on. But to manage the number of questions, it would be good if you could post your questions in the chat room. So Dr. Thomas, based on those numbers you just gave, is this complement of cardiologists adequate for the number of patients with cardiac issues on the Trinidad and Tobago?
I would say the main problem is not so much the number of cardiologists, but putting systems in place that that function well. So you will find that a lot more cardiologists in one area, one particular health authority, may address the same number of patients. So the limiting factor, yes, staff is one of them, whether it be the doctors, then it'll be the nurses, then it'll be technicians specified in various fields like sonographers, etc. But from my experience, it is really more a problem of putting in some structure in systems that work. So we have patients who are waiting very long for appointments for clinic assessment, non-invasive evaluation, cath lab procedures, pacemakers, surgery is a very long waiting list. As admissions are concerned, patients are coming into the emergency room and taking more than a day or 2 to get admitted onto a regular ward or a cardiac facility. The funding and putting in place systems so that the procedures can be done, from simple procedures like echoes, that tends to be a gatekeeper holding back a lot of patients from getting the appropriate care. Now, you have to add to this the third tier, which is the primary care, which is the family doctors and the doctors in the health centers. There is a tendency for some patients to want to be evaluated in a hospital clinic, and that puts an additional burden on the hospital clinics. So if the primary centers were given the tools they needed to be able to manage patients efficiently and in a manner that simple heart problems can be addressed, hypertension managed, diabetes control, hyperlipidemia, etc., then there will be less patients falling ill having to be going into the emergency room of the hospitals or wanting to be going to the cardiology clinic, and they'll be free. So there's no reason, for instance, if a cardiology clinic be established in a local health center, that will relieve the burden on the cardiology clinic at the general hospital. So although you may say there's an issue in the number of cardiologists,
yeah,
I think the main problem is putting systems in place so that the clinics work, so that the appointments for echoes work, so that the patients don't have a waiting list for all these various things.
Okay.
That is where I think, and Dr. Ramroop would have knowledge of what happens in the emergency rooms of the hospitals in Trinidad and Tobago, where sometimes we're getting a lot of people with chronic diseases taking up half of the beds in the emergency room.
Right. Yes, I'm sure that is a challenge. So before I bring in Dr. Ramroop to tell us about his area of expertise or orthopedics and surgery in general, we have a couple of questions in the chat function. So you said that there's no full-time cardiologist in Tobago, Dr. Thomas, but you visit there once a week. What's your caseload in Tobago, and what types of interventional work do you do in Tobago?
In Tobago, there's a lot of hypertension. Lifestyle is also leading to patients to develop obesity, diabetes, and as a result of that, we are seeing people with heart failure, coronary artery disease, arrhythmias. Patients are being admitted with acute myocardial infarctions into the hospital. And I will see patients at the clinic of the public hospital, as well as at a private clinic at Calder Hall in Tobago. The facilities in Tobago, a cath lab was actually built. It was run for 1 year, but it has not been recommissioned as yet. Therefore, patients who need cath procedures, angiograms and angioplasties, have to come to Trinidad to access that privately, or if they are a patient of the hospital clinic, the hospital can apply for the patients to have access to the Ministry of Health program. Of course, that then provides a waiting list that they're very uncertain when they will eventually be seen.
Okay.
That non-invasive procedures like echocardiograms, they have contracted my company to read those echoes for them. And the other tests they are able to do. Drugs are available in the public sector. Sometimes there are shortages of some of the more expensive drugs. So in general, Tobago should be able to have their cath lab functioning, although it is a small population, about 60,000, so it's under 100,000. And that's a small population to have a cath lab. They're separated by the sea from Trinidad and Tobago, so it is my feeling that they should find a way to get that cath lab commissioned, and it may even be used to help with the backlog in Trinidad.
Yes. Okay. Very interesting
The last point I would make is that there has been a very interesting study with a colleague of mine who was passed, Dr. Alan Patrick, who did work with the University of Pittsburgh. And they got very interesting information on the population of adults in Tobago, finding out that number one, high blood pressure is very prevalent, and so too is left ventricular hypertrophy. I would like to add that at the present time, we have submitted an NIH grant, and we're waiting on word as to whether we'll be successful with that. to study the Tobago population in even more detail, to look at the factors. Well, it's an epidemiological study. We'll be looking at all of the factors related to the development of the weights and the BMIs and the blood pressures and the glucose and the cholesterols and the carotid artery intimal thickening, as well as ECG evidence of left ventricular hypertrophy. And this time we're going to add echo evaluation of the heart. There are two things in particular that I would say are more common in the Tobago population. One is definitely the hypertension and the left ventricular hypertrophy. And there also is an incidence of amyloidosis, which is being recognized more and more in the international cardiology community.
Sorry, Dr. Clifford, but you say a higher incidence of those conditions, and there'll be a study to undertake, but is there any current thinking of why Tobago will have higher prevalences of left ventricular failure and hypertension per population than in Trinidad? Is their lifestyle so much different from Trinidad?
Well, Tobago population is an interesting population because it is practically 90% an African-based ethnicity population. Yeah. So it lends itself perfectly for a study where we can evaluate what's the difference in the African diaspora in terms of certain heart diseases. So we are comparing our data with data from other studies in the United States. So we should be able to answer some of those questions. I would say that some of it is genetic related and some of it is lifestyle. And it's more or less a combination of a predisposition to having more hypertension and a lifestyle that makes that hypertension express itself earlier in life.
Sure.
And with more severe numbers of blood pressure and with complications which develop earlier.
Sure. And Dr. Clifford, just one, Dr. Thomas, sorry, one last thing before we bring in Dr. Ramroop. You say lifestyle, and for many people, I mean, that's a broad statement. Is it a sedentary lifestyle people are more living? It's less active? They're eating more certain types of food than is advised? What it is about the lifestyle that is contributing to this hypertension?
So that's an excellent question, but I'll make it really simple. The problem is metabolic cardiac. So the problem doesn't start cardiac. It's a metabolic cardiac issue. So the metabolic part is what we are putting in terms of the fuels we're putting into our body and the amount of work our engines of our body and muscles are doing is resulting in maybe additional salt, too much calories of a poor quality, not enough healthy nutrients. The result is weight going up, cholesterol going up, sugar going up, blood pressure going up. And these things lead to vascular problems, eventually atherosclerosis, putting patients at risk for coronary events, cerebrovascular events, kidney disease, and heart failure.
Okay.
The lifestyle that we have is everybody is using motorized transport. Very few people are walking. How many people here walk 45 minutes to work or to or from work? And you'll find that people who do that, it's because in addition, apart from going to and from work, they find 45 minutes to exercise a few times every day.
Yeah.
I suppose many years ago that didn't occur. If you want to eat food, you've got to go and hunt. if you want to work, you've got to go and, you know, walk to work. So that lifestyle, and then the processed foods which we have nowadays, going to the supermarket, and we are getting the wrong types of carbohydrates. We're getting carbohydrates with not the correct glycemic value. We're not getting enough vegetables. We're getting too much salt added. All the processed foods are sweetened. Flour is a serious problem. Flour is a serious problem. And, you know, our proteins are not the healthy proteins. We are eating processed meats. I don't know anybody who has a fowl in the backyard and eating chicken breast anymore. You know, you're getting processed meats. So all of those things are leading to the problems which reflect itself in those parameters which I told you, which then lead to heart disease.
Sure. Thank you so much, Dr. Thomas. It's very insightful, some of the things that you have said. And we will come back to you, of course, and we have a question which I'll come back once we've gone to Dr. Ramroop now. So, Dr. Ramroop, let's come to you now. You're a surgeon, and you do, you know, general surgery, but you specialize in orthopedics. But from your experience and expertise, what are the most common types of surgical procedures in Trinidad and Tobago? In terms of your area of expertise, sort of what are the most common types of surgery you're carrying out now, and what would be the typical surgical pathway for that area of surgery?
Well, as Clifford was saying, it depends on which sector you approach, and because our country has a sort of dual health system, we have the Ministry of Health, which is administrative, and we have the regional health authorities, which are under what we call the service level agreement. Is a series of metrics that they must, all the RHAs from Tobago, northeast, northwest, central, eastern, and south. Those are your RHAs, and they are the deliverers of healthcare, as it were. Then you have the private sector, from the private hospital institutions to the general practice clinics, and like me, I'm doing my home clinic. Yeah. So basically, if you're looking at the common or garden procedures that are done surgically, it will depend on which specialty. In terms of the general surgical, I'm not a general surgeon per se, but some of my colleagues, for example, most of the common surgeries they'll be doing will be a lot of lumps and bumps, a lot of hernias, right? Umbilical, inguinal hernias, right? And in orthopedics, the most common procedures are arthroscopic for osteoarthritis. We have quite a lot of osteoarthritis in our clinics because of degenerative, because of obesity, right? So a lot of lifestyle type problems that are coming in. You know, lumps and bumps, as you know, I mean, in all the surgical specialties, whether they be adenomas for breasts or lipomas, neurofibromas. So they're quite a lumps and bumps. In terms of ENT and some of the other surgical procedures, the common ones, the tonsillectomies, the thyroidectomies, and most of these are the common types. In terms of general surgery, we have a lot of diabetic work. For example, on any one admission day, my son is also a house officer. He's doing his MRCS right now, his MRCS Part 2, and he's doing surgery. He was in thoracic surgery, he was in neurosurgery, he was in general surgery, and now he's in ENT surgery. And he does confirm that a number of the cases that are coming in when he did general surgical calls are diabetic related, amputations, a lot of debris mass, right? Quite a lot of dressings, a lot of ischiorectal abscesses and perianal abscesses. These take a lot, right? Of course, you have your routine elective OBGYN cases, but of course, quite a lot of hysterectomies, a lot of problems with gynecological problems, a lot of the need for drainage of abscess, and of course, fibroids, you know, for quite a lot of uterine fibroids in terms of the OBGYN type procedures. Those take up most of your list. So if you're doing an orthopedic list, you would have a lot of common procedures: a minor fracture, a wiring, a ganglionectomy, a carpal tunnel. These take up a lot. Then, of course, you'd have your fracture work, trauma. In most of the acute care hospitals, trauma constitutes about 24% of the admissions, right? From lacerations due to chop wounds, gunshot wounds, motor vehicle collisions. Of course, during the COVID, that was a bit less, thank God. But yes, about 20 to 30% are due to trauma in most of the institutions in Trinidad and Tobago. The surgical system in Tobago is similar. With the new hospital, they do have a surgical suite. They do have surgeons. I know some of them. In fact, when I go to Tobago, I do go quite a lot. Two of my nieces, one of my niece and my cousins, they are doctors there. So we do go there and see, help them out and, you know, take a look at what's going on. And similar. Most of the cases are mostly common organ hernias, and in terms of the emergencies, those are elective cases. In terms of the emergencies, a lot of appendectomies, again, acute abscesses, right, in terms of general surgery.
Right. Okay. So Dr. Ramroop, you're in private practice. In terms of going into private practice and setting up your clinic, you said you're based at home. What was there some sort of minimum standards criteria before you could set your business up to carry out surgery in your practice, like some sort of a regulator or an inspector who made sure they had minimum standards in this facility to carry out your clinical work there?
Well, the answer to that is yes and no. No, in the sense that there's no formal institutionalized regulator. Your regulator is basically your peers in terms of your peer review, right? Your colleagues, your medical board. Every year you renew your license. And of course, if there are no reports from you, either from patients or the public, when they look at the, you know, they just renew your license. If there are no court matters, or you're not have been in the public eye for any problems. Of course, in terms of regulation, the private hospitals are regulated by a private hospital board, which is actually supervised by the Ministry of Health. I'm not sure how well oiled that is, because in my opinion, we have good healthcare. We are regulated by our peers in nursing, and particularly in surgery, and particularly in the medical field. And it's a more ethical type of review rather than a systemic, and in terms of the environment of care. The environment of care is pretty important because, you know, things like public health, the public health issues are actually looked at by OSH. The OSH inspectors do come to some of our offices and look at how we get rid of our waste, our shops. They look at our waiting rooms. They have visited me in terms of my washrooms, in terms of the area that we have for the waiting room, and how I remove my waste from the building, my medical waste, you see. So there are some sort of government controls, but these are more from the OSH, the EMA, right? Before I set up my office, I had to go to the EMA so that there were people around me, you see, to make sure that I didn't have any medical waste in the area. Okay. So these are some of the things that the big nursing homes, for example, how they dispose of their dead bodies, in terms of where does the funeral parlors come and pick up the dead? Do they report a possible coroner's case? You know, so there are certain legal systems that, just like in most of the world, that they must abide by. If there's a case of possible child abuse, there is a system by which they will report it to the authorities. So there are some it's not really bad, the healthcare in Trinidad in terms of those systems, but I think it has to be more managed. And of course, it has to have a more institutionalized regulator.
Sure. Okay, thank you. We have a question from our participants, surgical question, which I'd like to put to you, Dr. Ramroop. And the question is laparoscopic surgery practiced more regularly now in the varied surgical specialties? Do you know? Yes,
the answer to that is yes. Most of our, well, I mean, I'm 59 years old, so I wouldn't say younger, but most of the younger physicians to me, and some of my colleagues, they have been doing quite a lot of laparoscopic procedures in the private sector, as well as in the hospitals. And the answer to that is definitely yes.
Right, okay. And we have another question, which is, in fact, I'll put this to Dr. Thomas. Dr. Thomas, are there any continuing medical education requirements needed for renewing medical licenses?
So there are ongoing CMEs where doctors attend courses, etc. They are basically, you are encouraged to do that, and you will have a log of what courses you have gone to, but at the present time, there is no requirement for you to maintain a certain number of hours in CNEs to be able to continue with your practice, or any exams for you to have to write every 3 or 4 years to be able to maintain your license in your field of specialty. So if you have been qualified and are certified as a cardiologist by the Medical Board of Trinidad and Tobago, we can continue.
So if you've done no continuing professional development training for, let's say, 20 years, can you continue to practice?
Well, you shouldn't. But I think that and can correct me if I'm wrong, they leave some of that on the onus of the physician to continue to update themselves on what's happening in their fields. And what the selectors to becomes the patients and the referring doctors decide if a doctor is not keeping up with their fields based on the results and so on and so forth. So as far as I'm aware, there is no requirement of having to do this. But most doctors, I do know in my specialty, attend courses internationally, regionally, as well as go to continuing medical sessions locally. So they more or less, certainly in my field, and I know in the surgical field as well, they do take it seriously to keep themselves updated, because if they don't, they do find that it affects them in terms of the patients who see them. Now, in the public sector, that's a little bit different. And I think that the public sector, both the public and private sector, should have some requirement to ensure that doctors are keeping abreast of the information in their field.
Sure, thank you. And just building on that, Dr. Ramroop, what's your view then? What's your view on whether there should be mandatory CPD for all doctors to maintain their license in TNT? And if so, do you anticipate any barriers for that happening?
Well, the answer to that is, well, it's obvious. It's a rhetorical question, I must say. There is a need. We have international and global standards. Of course, the world is just opened up with the virtual space. And I mean, you can't afford, as Clifford was saying, you need to have a competitive edge, no matter how old you are and you're practicing. And one of the things that I would just like to add, that a lot of the private sector, the bills are paid by insurance companies. These insurance companies, they do have very strict standards in terms of the doctors that they use in their system. They don't just go and hire 20 doctors and say, go by anyone. They actually choose a select number of physicians by which patients could go to. In fact, they give them cards, and they have a select team of physicians that actually could access those. So again, there are some controls, but again, in keeping with what Clifford was saying, we do need to have a system in keeping with global standards, even regional standards. In Barbados, it's much more impeccable in terms of continued medical education. There are going to be mental blocks. You know, one of the things that when I was medical director at San Fernando, I had started to introduce a system of measurement and performance indicators within the physician population. And I was, at that time, maybe I was a couple of years, about 10 years ahead of my time, I think. I didn't have the support of the executive. And therefore, I was actually literally almost abused, you know, in terms of what I was trying to do. Because, for example, we were not measuring clinical practice. We were not, the medical chief of staff who was there before me didn't hand me over a file to say, well, look, this is my hospital infection rate. And this is what is compared with Port of Spain hospital infections rate or Sangre Grande. Am I better or am I worse? This is my bed stay. This is my throughput rate. This is my estimated waiting times, you know, in casualty. This is my waiting list for elective surgery time. And therefore I couldn't use these as benchmarks, because I can't improve something if I didn't know what it was the baseline to improve from. You see, so, and I agree with Clifford, the challenges that I had wasn't so much at the public sector in terms of the public healthcare system in the surgical field, but as the medical chief of staff, I was responsible for the entire professional team. And I think that part of the problems is that the heads of departments, for example, in the hospitals, they are not really heads of departments. They are just heads of the doctors. So what is happening is that you might have controls within your department, but it's basically what you're really doing is signing rosters for your doctors and not really having an integrated approach to the whole question of continued medical education, you see. A lot of the continued medical education sessions are held by, for example, the Medical Association. And quite a lot of those are just drug companies who are advertising their drugs, would have a meeting and invite a lot of the doctors to come to this meeting. They get some good food, get a 15-minute boring lecture, as it were, and then that's it. And then they get a CME credit. So I think that after a while, for most of us who have other good things to do in our lives, we sort of came away from that. But one of the things is that once you're a member of a college or a Royal College, I am a fellow of the Royal College of Glasgow as well as Edinburgh, and within that fraternity, we have to read journals. As part of me getting paying my fee every year to be part of this college or these colleges, we have to send to them some of the journals. For example, I read the Journal of Bone and Joint, and I have to read it, and I have to share that with my colleagues at the Royal Colleges to ensure that they are up to date, that I am up to date, you know, with my readings. So again, some of the colleges that we have, once you're a member or fellow of some of the big colleges around the world, they do have that sort of peer continued medical education requirement. And I think the COVID has done a great job, because I see now that even my Royal Colleges of Edinburgh and Glasgow, they're strengthening that part of it, so that we now have to virtually report almost on some of the journals. And then they'll send down some samples of some questions, and then we'll have to research it and send it back to show that we're actually reading these journals. So I think that in a sense, that degree and the competitive advantage in the private sector runs this, but it cannot be allowed to continue too long into the future. The population, our people, the people that we are serving, continue to demand more. And I think that is the trust. We have always had a physician or clinical driven healthcare. What we really need to have is a patient driven healthcare, where the patient's demands actually tailor the needs of the patients rather than what the physician wants to do. As medical chief of staff, my biggest problem was that the doctors, the senior physicians or surgeons would come and say, I need 25 hips. But then I asked them, well, what is the prognosis of your hips? What is the quality of life after you put in the hips? When you put in the hips, did you follow them 3 months after? How soon after did you have physiotherapy? And the physiotherapy is overwhelmed. Some of these people, you put in a hip and they don't have physiotherapy for 3 months after. So then you're spending money on hip surgery, but you're not measuring whether your hip surgery is allowing these people to go back to the post office within a week, like in some of the other countries of the world. So I think these are some of the issues we have. And CME is fundamental to that, because CME is not just about clinical practice. CME is about the overall practice of medicine and surgery. It's not just going and reading a journal in your specialty or listening to somebody talk about, you know, the approaches to the cervical spine. It's all about how we deal with people. And I think that is some of the things that we need to formalize.
Thank you so much. Caroline, can I ask you, I don't know if I've missed a question. Was there any question I missed which you've seen on the chat panel? Because you...
No, I think you've picked up most of them. There was one question, we've talked a bit about the board, so I think that is generally it. There was a question early on about heart disease management, but I think we've covered that. I think we've covered most of the questions. Oh, there's one question here about who regulates the medical board. Is it the Department of Health or Ministry of Health? That was one question.
Okay, who would like to answer that? Let's go to you, Clifford first. Who regulates the medical board or?
So I'm not the person to answer, and I'll give you the reason why. Large institutions can really be difficult to work with. And I actually was working at a senior level, both within an academic institution as well as a healthcare public institution. And one of the things that I found was that people are resistant to change. You have systems which don't work, and people are resistant to change. if the change might mean that they've got to be more efficient in terms of the things that they do. And based on that, I had been in a position where I was asked to take over the head of the National Cardiovascular Program. But my feeling was that if I did accept it, they would probably fire me within 6 months, because I would do what I think is necessary. People would not be happy, and there will be complaints. And instead of people sitting back and looking and saying, well, what is this, what is that? Is people are worried about, he's making the thing work, and this is going to affect my this, and this is going to affect my that. And like Stephen, I'm 59, and a few, I said to myself, you know what, I'm going to do my thing. I do miss, I be honest, I do miss the academic life. I do miss the big institution. But as we say, it's just, you get sometimes a feeling of spinning top in mud. And unless you feel that when you're pressing for change, the system is ready for people who are thinking forward and ready to make those things, it can be difficult. So I sit back, and if I see an opportunity which I can engage in, that I think, you know, it's not going to be time wasted, etc., then I'll get in. So that's a long answer. So I don't follow that much, and I think Stephen might have a better answer as to who regulates that.
Okay. Thank you. Very interesting answer, Dr. Thomas.
Yes.
So Dr. Ramroop.
Yeah. Well, the regulation really is self-regulatory. The Medical Act, the Medical Board Act, is very strong, and it allows for that self-regulation. But there was a little incident about 8 or 9 years ago with that same regulation, and the Ministry of Health wanted to bring in some Cuban doctors. And then they realized that because of the self-regulation, there were some mental block issues, and as Clifford was talking about, resistance to change. So I think they went into the legal system, and now the Ministry of Health has appointments on the medical board, right? And I think that has made it a little more balanced with respect to how the medical board deliberates, right? And because before that, it was purely a self-regulation. Doctors would nominate they will have these meetings, the general meetings, will attend the AGM. And once you're a licensed physician or surgeon and you attend the meetings, you can vote the board in. And that is how the board continued for many years. And now I think it's a little better regulated in terms of the question directly. Yes,
sure.
That's basically it.
Okay, Caroline, did you want to ask a question?
Yeah, I was just going to say there was I suppose in terms of the conversation, I don't want to take it back, but there was one question that came on earlier on, and it's one of the first questions, and it was around rehab pathways following strokes on major cardiac events. So I suppose that would be to Dr. Clifford, in terms of, is there a rehab pathway following strokes or major cardiac events?
So that's a very good question. Clinical pathways, and those of us who work in the United Kingdom, United States, Europe, we are familiar with the process of clinical pathways. It makes things so much easier. You follow guide-based, your evidence-based practice guideline. Are you following the guidelines? You can use clinical pathways for the patient with heart failure, acute coronary syndrome. So the answer is they have been used in situations that are not necessarily across the board nationwide. So the pathway that a particular hospital might use for the acute coronary syndrome, different from what another one does, from what another doctor might do on his own. So most cardiologists tend to follow pathways that have been set up by the European Society of Cardiology or the American Heart Association, or one of the British or European societies. Pathways make make the function of large departments uniform, predictable. You actually know where you're at. It is easier to follow. It's less likely to be missing things.
Yeah.
It's easier to be audited if you're following the various pathways, etc. And they should be used.
Yes.
That is the standard nowadays.
Yeah. So there's greater consistency, obviously, but can I just check, in the absence of national designated pathways or expertise designated pathways, you said there were 6 cardiologists at Mount Hope. Is there potential that each of those 6 cardiologists will follow different pathways despite working in the same institution?
So there is a pathway for a patient coming with an acute myocardial infarction.
Right.
It would be somewhat modified from some of the pathways which we use, but it may be tailored to what happens in that hospital in terms of what is available and what the patient can have access to. But the pathway becomes a bit difficult if what's limiting is not step 4 in the pathway, but the fact that, well, there's no bed on the ward for the patient to move, and the patient is shortly in the emergency room for 2 days. So there are other factors which make the pathway, well, why bother with this? Because it's not relevant, because it's supposed to be in a telemetry bed, and they're still in the emergency room for after 48 hours with a suspected acute coronary syndrome, or the person should have had a CT on admission, or the patient should have a coronary angiogram within the admission for an acute coronary syndrome, and it's 1 year later and it hasn't been done.
Right.
So in that setting, it becomes difficult to use pathways when there's so many other factors that are breaking the various steps in the pathway.
Right. Okay.
That's mine.
Thank you so much. I'm just going to, I think, oh, sorry,
Roger.
Caroline.
I said, Roger, there was a question that Dr. Jackson wanted answered in terms
Yes.
of, and I guess it's based on the PAHO data, it seems as if chronic diseases are increasingly disproportionately increasing in Trinidad and Tobago compared with other Caribbean islands who are less well resourced. And do you have any insights on this?
Well, there had been a degree of affluence in Trinidad society, and affluence combined with Western style living, it's a perfect storm. It's got to lead to heart disease. So we already have this so-called affluent, this Western lifestyle, which we talk about is the certain foods that we eat and the lack of exercise. I think when you add that additional aspect, what you then end up with is having perhaps one of the highest incidences of obesity. I think Trinidad was rated somewhere in the top 5 in the world. We have a terribly high incidence of diabetes in Trinidad and Tobago. So, so Trinidad and Tobago is unfortunately leading the world in some of these lifestyle problems that lead to chronic non-communicable diseases. And that is also echoed throughout the Caribbean. It is echoed throughout the Caribbean.
Okay.
These affluent lifestyles can occur even when the economy is not good. So the affluent lifestyle of those foods that we eat and spending time on cell phones and computers instead of walking around and doing the various things,
yeah.
Even though you may be considered in terms of the economy, not really an affluent country, you are following the bad lifestyles of that affluent communities, and you are developing these risk factors for heart disease and and shortened lifespan.
Sure. So Caroline, did you want to say something again?
Yeah, this is a question for both Dr. Ramroop and Dr. Thomas. What area in your particular specialities would you identify an urgent need for intervention or assistance if offered assistance from the relevant capable bodies? So in both fields, what would be?
Yeah, let's start with Dr. Thomas, then we'll go to Dr. Ramroop.
Oh, I would say IT systems. IT systems that allow you to be with the global trends, electronic health records, computerized databases, an ability to share information easily, ability to record things on digital format, scheduling. Would you believe that hospitals, massive hospitals, make appointments for clinics on paper? It boggles my mind that this poor clerk has got to change the date and the name and the number each time when there are so many platforms available free for electronic scheduling.
But Dr. Thomas, sorry to interject. So then if you're saying some of these facilities are available free, what is the barrier for implementation? Is it again down to resistance to change?
Well, it really you're boiling some googlies there for me. How that's a no ball. Difficult to answer because it is easy. It is not difficult to do. So I'm not asking for things which are very difficult, simple things that could make a world of difference. And I think that the IT has revolutionized healthcare around the world, and we should use things to make things easier for us. Doctors have to report on paper. A system could be available where the doctors can do the reporting, prime on an electronic format, and it can be easily moved. But you do it on paper, it never gets typed, the clerk loses it, it doesn't get to the patient's notes, and it's just, there we go.
Yeah. Okay, so we'll come to Dr. Ramroop about his, urgent need in a minute. But can I just ask one last thing on that issue, Dr. Thomas? Where are those conversations about improving IT systems being held at the moment then? Where is the forum for those concerns to be expressed? Just as you were saying now, by the medical fraternity, the nursing fraternity, other people that could contribute to quality improvement. Like where are those conversations held at the moment?
I don't know. I mean, those are the systems that are needed. I mean, when I was at Mount Hope, I saw the problem where we have got patients backed up in casualty, and I sought to find, maybe we could find a simple solution whereby we could figure out which ward will be on call on a particular day, so they'll be taking off the load on the hospital, put the load on an admitting ward. And there was resistance to the initiative to move on to something that could make things work, to scheduling patients electronically. I don't know the answer to that question.
Okay, no, fair enough. If we go to Dr. Ramroop, what about you in orthopedic surgery? I know you're doing your private practice, but what would you identify as an urgent need if the assistance was available from the necessary authority or body?
Well, I would like to probably change that question a bit, because I think the answer is not just so much in the specialty. Each specialty would have some similar issues, right? I mean, I would definitely endorse Clifford's need for IT, but it's a broader problem. It's a management problem. If we need to get help in this country, we need to get help at a management level, because what Clifford is talking about is just one element of a management or business process, right? Which is not just in the private sector, but in the public sector. The Ministry of Health has what is called a service level agreement, right? The RHAs are supposed to follow that instruction to the book, right? The level of discussion you asked about is at the board level. All of these RHAs, they have boards, and these are executive members that are elected by the existing government at the time in terms of the political parties that come into power. So it's a political board, and that is where the discussions come. But they elect a CEO. These CEOs are supposed to be qualified, and then they will bring to the board, well, we need to have an IT system. So the answer to that, guys, it's an integrated healthcare problem that we're having. The way that we integrate our systems, and to do that, you have to have very common issues. IT or ICT is one of them, right? So if we have to answer that question in a purely management or orthopedic perspective, I would like to go back to what we call the Baldrige criteria in terms of we measure criteria at hospitals, right? There are 7 criteria. The first one is strategy. The second one is leadership. The foundation of this whole criteria, or the 7 criteria, is data, knowledge management, and information. That's what Clifford is talking about. And using that data, you can build on your business processes. He talked about pathways. Clinical pathways are basically standard operating procedures, right? By these standard operating procedures, you can map processes, and then you can actually monitor processes and evaluate processes and correct them or re-engineer them when they are failing, right? So business processes is one of those criteria. The next one is staff development, staff improvement, human resource development, training teams to understand the clinical pathways. Although you might have a clinical pathway to get into a certain tube into someone right as they come out of the ambulance system into your emergency room, which will include this prognosis, it's a multi-team approach. It's not just a doctor doing it. So that having a pathway, you have to train these people around that pathway. So that is very, very important in an integrated system. And that includes ICT as one of the fundamental cross-cutting pathways. It embeds everything, including gender and diversity. So these are the things that has to be embedded into our systems, you understand? And then I missed out 2, well, I didn't miss it out, we didn't get there. The last 2, obviously, is your customer relations, your customer focus. As I said, it has to be a patient-driven pathway. It is not a physician-driven pathway. It has to be based on evidence from clinical research and trending. And finally, it's reporting, monitoring, and evaluation, and measurement. Those are your 7 criteria. And those 7 criteria has to be integrated across the public and the private sector. And I think that is where we need help. So where we want to specifically state it is, if we can get executive coaches to sit with our clinicians and our technicians in the health system. Executive coaches is not a consultant that comes and tells you what to do, here what you have to do, and then write a whole report on what they tell you is what you're doing. An executive coach comes and holds your hands and develops those pathways, looks at the ICT deficiencies, look at the integration possibilities, right? Get all the CEOs together, get all the chairmen of the board together, create national policy, right? Float out the national policy, roll it out after 5 years, measure it, train young clinicians and technicians in the pathways. This is what we want.
Okay.
I'm gonna just up to the boat a little bit, if I may.
Yeah.
And I'm going to say something. If I would say what sort of help I would wish, I would put it this way. Identify a project where clearly identifiable service to a segment of the community of Trinidad and Tobago, where that service is not at the level which you want it to be, and decide, okay, Stephen, or Clifford, I would like to do something about prostate disease, that's a problem, about hypertension in a community, about patients having access to care with a heart attack, and sit down and create a plan to manage that with the resources available, and say, these are the resources I have available. In these various areas, I'm deficient with this, that. Can you help me in this area with helping to plan it to get it together? In this area, help me to market it so that the community knows what we're doing. In this area, helping me to get the IT infrastructure that it could work. In this area, help me to partner with the private sector to get this done. In this area, help me to get to lobby with the Ministry of Health or the RHA for them to realize how this could benefit them, that this can help me to the lobby with the people who vote, who are going to put some pressure on our leaders to make it happen. So I would say, if I were to say, I've got maybe 3 or 4 areas that I may wish I would like this project to work, not in my little office here, but maybe in a larger community in the public sector. And what resources can you bring in on the table, starting with putting minds together to make that happen? That's, and now to go back to what Stephen said, address each of those pillars which you talked about and say, well, we need help with this, that. Out these 4 we might have enough, but here's where we need a lot more help. And what you find is that the assistance tends not to be a financial matter. Yes, sometimes finances are going to help, but it is just basically putting minds together who are able to think outside the box, look at stakeholders, lobby, bring things together with a focus on delivering a result. And then when it works, it could be a small little thing. You could then say, listen, it could work. We did this in a small little clinic in so-and-so part of Tobago or in so-and-so part of Mayaro, and there's no reason why we can replicate this in other clinics or other hospitals or nationwide. That's the way I would go about it. Select something, not necessarily a nationwide project, but something which can be relevant to the nation, which then can be looked as a pilot study. It worked, you do this, and we can make it happen. Those are my thoughts about that.
Sure. Okay. Thank you very much. We have 9 minutes left, and I just want to just see, first of all, is there anyone who of our participants have a question which they would like to put verbally to our panelists, Dr. Ramroop or Dr. Thomas? Just raise your hand. Yeah, unmute yourself, Stephanie.
I have a question.
Sorry. Yes, Stephanie.
Yes, Dr. Thomas, do you think one of the contributing factors for Tobagonians, when you look at the ratio of hypertension, diabetes, and all of that, could it be because of the profile of the population? Because quite a lot of people there are over 50. And that could be one of the contributing factors. I've worked in the public health scenario as a district health visitor, did a lot of chronic disease clinics, and worked as one of the nurses at Eric Williams Medical Sciences Complex. So I have an idea in terms of the morphology of the people, and they're predominantly the lifestyle and the diet. The diet too is quite unique. They eat a lot of salt, a lot of coconut, and generally sedentary, but a lot of them are elderly.
Okay, thanks, Stephanie. I want to be concise. Dr. Thomas, is age also a contributing factor for the level of heart disease in Tobago?
As we get older, we're more likely to have heart disease. I think that it's a combination of genotype and environmental factors that result in that heart disease. To make it really simple, hypertension is 95% essential and 5% secondary causes. But some of that essential hypertension is probably some gene malfunction that has not yet been discovered that makes them more susceptible. So faced with the same environmental factors, they have a little bit more hypertension, or it is more aggressive than other people. So that's my answer.
Sure. Thank you very much. Anyone else has a question for our panelists? Just raise your hand and now we'll ask you to unmute. Can't see any hands or questions. Caroline, were there a couple of questions on the chat thing or comments? I think I saw. You're on mute, Caroline.
There was one question here about a view on implementing telemedicine in our public and private healthcare settings. What are the views on that by the panel?
Can we go to first Stephen and then to Dr. Thomas? Do you have a view on it?
There is a role. There is a very, very good role, especially for specialist care. The traditional programs that we have, it's such a small country, guys. It's so small, and what we have really is a lack of specialist care at the level of the district health facilities, like Mayaro, Cedrus, these far points. So I think that to prevent a lot of persons from leaving these places and coming into the clinics, suffering long hours of traffic and hours to meet with the specialist, and then when they go there, they meet an intern or a house officer who actually books them in and gives them a 3-month appointment. I think this is where I think that a lot of the regional health authorities can assist by having telemedicine portals in a lot of these district health facilities. Even it's just a matter of engagement, looking at clinical. One of the things you must understand, and Clifford is saying, is that fundamental to all of that, my 7 criteria, involves leadership. And at leadership level, we have to have legislation. We don't have the equivalent of HIPAA, like what you have in the US. So floating around images is illegal in Trinidad, really, it's illegal. Okay. So that what it is basically is that you have to look at the legislation, and it has to be more modern in terms of accepting, as I said, the cross-cutting pathways of almost everything, gender, ICT, climate change and environment. These are the cross-cutting pathways. So we have to introduce that into our systems.
Sure. Okay. Anything else, Caroline?
I think it's here to stay, telemedicine. The mere fact that the COVID pandemic occurred, we were forced. You'll have patients who literally will call, and whether you're doing a simple teleconference and listening to the symptoms and screening them to tell them whether to go to a COVID center or whether you can go safely to a doctor's office. That was the beginning of telemedicine being used on a more frequent basis. Anyway, so just a simple telephone call had to be done, and I think that being done, you question some of the face-to-face interactions that we do, how necessary they are. Here we are right now in a meeting which we would have probably played airplane trips for us to meet in some conference center to sit down and chat. Yeah. And some of the things that we are doing, we didn't. And we're suddenly realizing we can do this free. Yeah. So it's here. And I think you have to sit back and look and see how can it be best used in where I am. All new technology has got its good and its bad. So you don't want to abuse it to the point that you are impairing the care of patients, but you want to make sure that you use it where it's relevant and can be helpful to the stakeholders that involved in this whole healthcare process.
Okay, thank you so much. Well, I'll just take the last couple of minutes just to wrap up. So thank you, Dr. Thomas. Thank you, Dr. Ramroop. It's been engaging. Thank you for your insight, what you shared with us. We heard about, you know, the challenges, I suppose, with regards to heart disease in Trinidad and Tobago, particularly in Tobago. We heard about surgery processes, and particularly in the private practice, and how some of the challenges you faced, you know, in your own profession as well, and some of your insights of how things can be improved. So we're very grateful for that. For TTHUF as a charity, we are always looking to engage with the clinical staff, the ministers, etc., so that at the end of the day, as it has been said earlier, I mean, Dr. Ramroop, you said it, it should be patient focused. Does the general population, people who receive healthcare, what do they believe about the quality of healthcare they receive? And if the majority is satisfied, then you use that as a barometer to whether the care you're delivering is meeting the needs of the population, rather than, you know, either the people who either medical staff, nursing staff, etc., saying their programs are good, and we're not hearing the patient voice. So you mentioned about the patient-focused approach as well. So I want to bring it to an end now. I think this is a start. This is not the last webinar we want to have. We want to have different staff. We want to have nurses. We want to have other people working in the health sector who would come and give their views. And hopefully with this coordinated approach and insight, we can have a better healthcare system in Trinidad and Tobago. So thank you so much for your time. Thank you for dialing. We appreciate it.
Welcome.
Dr. Ramroop, Dr. Clifford, we're grateful, and we'll be in touch. You've been great, and we'll be glad to have you at some other time in the future again. Okay, thank you all. Have a safe evening wherever you are in the world. Take care.
Thank you. Bye.
Bye.
Bye.